Good morning, and thank you so much for having me here. I'm, of course, thrilled to be back. Many of you know I spent about 35 years in Boston. I actually graduated from the School of Public Health here, from this wonderful university, and did a doctoral program between BU and Brandeis. So I appreciate the students who are joining us both here and virtually as well. I think you're at one of the premier places in the world to get grounded in an education about how you can go forward and really ensure that everyone has resources, opportunities, and power that's needed for optimal health and well-being. And I want a special thanks to Dr. Galea and to Dr. Fabian for having me here. Your leadership here has been instrumental to, I think, preparing future generations of public health practitioners. And I'm also really honored to be here with the esteemed panelists that I'm going to be joining with in a minute. See if I do this right. There. I'm really going to start just sort of talking more globally about what we might have learned from this pandemic, starting with the fact that for cities to thrive, they've got to address some issues that have been with us for decades, although certainly the last 3 years during the pandemic, they've been made apparent not just to a small group of people, but I think to millions of people across this country and across the world. I want to start with the issue related to disproportionality, and I want to start with this because we saw a lot of disproportionality. I'm going to show some data on this in a second, but you cannot have thriving cities if you unfairly allocate the resources that people need to be healthy, and that's what we continue to see in the way we organize our cities. The policies, the systems, the practices, they all need to be realigned. We've also neglected worker safety, and I'm going to show some data on that, which I think is fundamental to a justice-oriented agenda. And occupational health and safety gets left out of our discussions way too many times. I think we've all learned it's not just that public health isn't funded, it's that it's not understood what our purpose is. And if you understand what our purpose is, it's not sufficient to think about just funding public health departments. So we've got some big challenges around how we think about public health. And then I think we've all been living with, and all of you here, I don't need to talk too much about this because I think you are acutely aware of the fact that we have policies and practices all over the place that make it hard to get the kind of information that we need to better understand the world that we're living in, and more importantly, to get information in a way that's easily accessible to the people who give us the information. So it's not, the information doesn't belong to the researchers or the academics or the public health departments. The research and the data we're collecting belongs to the people who live and work in our communities. And we still have so few technological tools, so few resources that are dedicated to that issue of, it's more than transparency, it's really sharing in that sort of joint understanding to figure out what's going on. I want to just, sort of for each of these issues and challenges I've identified, I want to just share a little bit of data or some examples. This is the all-cause mortality rate for LA County. This picture does not look different for most other cities that are diverse. And it goes over a 10-year period, 2011 to 2021. You can see that green line at the top is the experience on all-cause mortality for Black residents. The blue line is the experience for white residents. The red line is the experience for Latinx residents. And the orange line at the bottom is the experience for Asian residents. So one thing to note is huge, huge, huge differences that have historically put Black African-American residents in LA County with higher rates of death than everybody else. But if you look at towards the end, what you'll see is during COVID, everybody's mortality went up. It was a big deal. I mean, we all read lots of research that was done that tried to explain the increase. But what we didn't see a lot of is sort of the fact that Black and Latinx residents actually had the steepest increase. For the first time in more than a decade, Latinx residents now have a higher rate of all-cause mortality than white residents. And most of this is attributed to what went on during COVID. And I just, to emphasize sort of what's behind the sort of all-cause mortality, this is a look at specific death rates for some common illnesses and diseases. And you can see that for Black residents, pretty much with the exception of COVID, where Latinos and Latinas actually have the highest death rate, consistently a pattern of inequity in health outcomes. And many of you already know that as we think about these inequities, it's not helpful to focus on personal behaviors. It's much more helpful to think about systems of care and systems that organize resources. And I'm going to try to drive this home a little bit with just some data looking at what was going on during COVID. Lots of people see that the mortality rates are higher for Latinos and Latinas and for Black residents and assume it is directly tied to the fact that we keep hearing that they have lower uptake of life-saving vaccines. And for sure, you can look at this data. This is looking recently. This is recent data, not during a surge, at hospitalization rates by race and ethnicity and vaccination status. And you'll see, without a question, the vaccines save lives and help people from getting severely ill. But what you'll also notice is that vaccines are not an equalizer. So just getting vaccinated did not change the fact that both Black and Latinx residents still had higher rates of hospitalizations. And if you look at this, you'll also note that the same holds true if you look at this by poverty. Now, poverty in LA County is highly correlated with the color of someone's skin. So most of our communities that have high rates of poverty are in fact communities where Black and brown residents are living. But here you can see just how stark some of these differences are, particularly if you look at both the experience, not just of vaccinated people, where again the vaccines provide everyone with more protection, but not the same level of protection. As a matter of fact, people in the wealthiest communities who are unvaccinated actually have a lower rate of hospitalization than people who live in communities with high rates of poverty who are fully vaccinated. So again, I want to note where you live has a huge impact on other contributing factors to health, and we saw that during COVID. So the solution to the inequities is not so simple as we needed to get more people of color vaccinated. That just would not have necessarily closed this gap. And the same thing, you could see the tragedy around deaths as well. Sometimes people sort of look at this and they wonder, well, if it's not something as simple as access to vaccines or even access to therapeutics, which is why I try to use more recent data when we do have therapeutics and we have access. And in LA County, we have, for both of those, we have a really good access. I would say that one of the biggest issues that contributes to the inequities we're seeing is both the historical context, people living in overcrowded situations, in highly dense neighborhoods. That's where low-income people live in LA County, and I think in many other cities. But I also want to say that exposure was a big deal in explaining sort of what we were seeing. The folks who, and you could see this clearly here, this is what we call an outbreak map. This is where we responded to outbreaks, 3 or more EpiLink cases at a site. Everything's reportable to the Department of Public Health. And you can see that over time, There were some sectors where we just had high rates of outbreaks. Where you see those big peaks, those are all our surges. But you can see here that restaurants, food processing plants, factories, retail, hotels, and transit, those workers were much more likely than everybody else to get infected. Those are also the workers that didn't get to stay home, that work. I mean, I went into factories where we had outbreaks, and the conditions are horrible, and the protective measures for workers are almost non-existent. They're overcrowded. There's almost no real air quality, especially if air conditioning is broken and windows don't open. And people are in close contact with lots of other people all day long. And those people who are in close contact with lots of other people all day long then go home to communities that are very dense and to housing that's overcrowded. And you got massive, massive spread. And that's what we saw, and that's actually what we continue to see. Every time we have a surge in LA County, the disproportionality grows between Black and Latinx people and white and Asian people. That gap just gets bigger. Every time we're not in surge and there's less exposures for everyone, the gap narrows. And we need to pay attention to that, not just because we're talking about COVID, but because that issue of exposures, whether it's exposures to oil and gas, refineries and oil wells that are right next to people's neighborhoods and schools, or it's exposures to bad air, or it's exposures to lead in the soil and lead in people's houses. Exposures really matter in terms of the inequities we end up seeing in health outcomes. I also wanted to talk a little bit about sort of the public health funding. I put this up, this is sort of our funding for the year we're in, not to talk about the fact that we actually have a fair amount of funding, but to talk about the fact that almost all of our funding, over 80% of it, is tied to grants and obligations for a set of particular services. It means it's not flexible. It's not flexible during a pandemic, so when you need to find quarantine and isolation housing, you're really scrambling to figure out where that's going to come from. It wasn't flexible enough to help us deal with making sure we could figure out how to get food to people. It doesn't pay for homebound services to get folks vaccinated. It's all very directed. And we're told what we need to spend it on, and we're told what those outcomes need to be. And those outcomes are usually very specific. They're not about improving the health of people whose health outcomes are the worst health outcomes you have in your communities. They're very specific to whatever the funding source. And we need to pay attention to that because in order for a public health system to work, you have to both invest in infrastructure and you have to allow for a fair amount of flexibility. And when we talk about infrastructure, and this is something I would never have really been able to articulate as much as I can now because I didn't really have this deep of an understanding pre-pandemic. Our CBOs, our community-based organizations, our faith-based organizations, they're the backbone also. They're the backbone of public health response and have always been. All of these are pictures of community activities, communities that helped us mobilize to get vaccines into areas where we don't have clinics, we don't have healthcare providers. We had folks that go door to door, our promotoras, our community health workers, giving people information, talking to people, trying to answer their questions, trying to connect people not just to vaccines and or therapeutics, but also to food. The last couple of things I wanted to just mention, because I know I'm running out of time, is we also have to pay attention to fractured trust, because this will defeat us as we try to move forward and build thriving communities if government is always continues to be seen as a non-trustworthy partner. We saw the ugliest examples of this throughout the pandemic, but I think we've experienced this before. And the way to deal with fractured trust is to acknowledge that there's a good reason why there's fractured trust. Many of the communities that don't trust us are communities where they frankly feel like and have been ripped off by government. where we haven't paid attention to their basic needs, and we haven't been supportive, and we go in with solutions that have no bearing on the problems and the challenges that people in communities face. So we have a lot of work to do here, and we all have to own this. We created this problem of fractured trust. It's been magnified with social media, misinformation, the politics of the time. But fractured trust was something that we've had for a long time and just didn't pay a lot of attention to it. And I'm going to close by just noting that I am not feeling hopeless. I feel like the picture, I paint is one of big problems, but we're a country where we've had big problems before, and we're very capable of coming up with appropriate strategies for addressing big problems. But we do have to organize. We do have to make sure that we build out a public health infrastructure by investing in community-based organizations, faith-based organizations. We do have to partner with labor and workers. We have to deal with, this has always been a place where public health has had a long history of improving the conditions for workers, and those conditions, when they improve, change health outcomes. If we look back in our history, you see that for every single big improvement in health outcomes, we were paying attention to workers. We're going to need to also deal differently with issues around sharing information. We got to create a two-way path to have information in real time. And lastly, of course, we've got to partner with others on the sort of addressing root cause issues. We've got to deal with racism, oppression, all of the isms that really stand between us and allowing us to create cities where everyone's going to thrive. Thank you very much.